Thank you for the opportunity to speak today, to relive, actually, mi peor pesadilla, caso fenestrado. These are my disclosures. Fenestrated and branched EVAR, what could possibly go wrong? As I thought about my worst nightmare case, I couldn't even choose, quite frankly. As we're learning this new technique, there are lessons learned from essentially every case, some of which are more painful than others. So instead, I thought I would try to make a comment on a type of case that I consider to always be challenging, always with lessons learned. And this is the case of fenestrated and branched EVAR after a prior EVAR. Several series have documented the feasibility of FBEVAR for failed EVAR. In this publication from the U.S. Aortic Research Consortium, among 893 FBEVAR, 18% were performed for failed EVAR. Clinical outcomes, including freedom from type 1 or 3 endoleak, freedom from reintervention, and target artery instability, were not different between groups. There were differences noted, however, in measures of technical difficulty such as dose area product and case duration, and this is absolutely consistent with my experience. These cases are just difficult. I'll try to give some examples today of how and why we've struggled in these particular cases, and I'll go over a little bit of the lessons that I've learned as well as I've learned them. So the technical challenges really take several forms in these cases. It cannot be overstated that these cases are just fatiguing for the eyes. There's a lot to look at and a lot to differentiate. And while the marks for the branches and the fens are always part of FBEVAR, there are now also marks from a prior suprarenal fixation stent or the top of the fabric marks. There are marks on the prior contra gate. And when gauging where to deploy a new bifurcate, often an inverted limb bifurcate, it's important to ensure proper overlap with the fenestration component, of course. And then cannulating that contra gate can just be really challenging through several layers of stent struts all kind of superimposed on one another. It's just very challenging to track the fine wire movements. Suprarenal fixation on the prior device can also sometimes make it difficult to track a balloon-mounted stent graft out into the target vessels. Even getting a sheath out into the target vessels can sometimes be challenging. And the technique that we commonly use to overcome that swallowing the balloon technique where the sheath is advanced over the balloon as it's deflated, sometimes fails because the balloon will just simply pop on the fixation strut as it's expanded. Fortunately, this has actually been less commonly a problem than I might have predicted. The other potentially challenging aspect has to do with both planning and execution of these cases. There's just increased friction between the new device passing through the indwelling device rather than the native aortic wall, and that can decrease the rotational ability. The way the device opens, particularly in the case of a tortuous segment, can also be far more unpredictable than usual due to the stiff nature of the prior aortic device's stent struts. This can make cannulation difficult due to misalignment. So you see depicted here in yellow, the old device has a vector kind of headed one direction, and the new device is in a vector that's in apposition to this. And it's just very difficult to predict exactly how that will cause the fenestrations to line up. Even percutaneous access can be more challenging in these cases. While the per-close instructions for use indicate that the device can still be used in cases where prior access has been obtained, my experience has often been that the additional scar from either an open cut down or even a percutaneous access can sometimes cause the suture not to track properly down to the vessel, or the needles not to penetrate the artery wall properly, leading to device failure and need for cut down. So now I'll go ahead and present a case to help illustrate some of these features. So this was a 58-year-old gentleman who'd had an endovascular aneurysm repair in 2013 with an Endologix AFX device. He was noted to have a type 3 endoleak and sac expansion up to 7 centimeters when he was referred to us. This was our graft plan. It was a 3-fen device due to a history of a prior left nephrectomy. With a universal bifurcate distally and then seal in our existing limbs distally. So we anticipated several challenges in this case, of course. We anticipated specifically that there would be device impingement on the right renal orifice, making it potentially difficult not only to cannulate it, but also to track devices out into it. It's also difficult to anticipate the alignment, as I talked about previously, with the vectors of the old device and new device not lining up properly. And again, there's just a lot of metal. That is truly one of the most important aspects of these cases in terms of operator fatigue. And we also anticipated challenges with these very tortuous iliacs. So again, tortuous iliacs are always a problem, but even more so in the case of a indwelling EVAR device because of the additional friction, etc., as the device is passed through those limbs. So we were prepared. Intraoperatively, we started by cannulating the right renal artery to ensure that we could get into it easily and see if we needed to balloon it, anything of that nature, and in fact, it looked fine. We adjusted our fusion marks as we normally do and then oriented our device for advancing. We used hydrophilic dilators prior, which is a common practice for us prior to introducing the device. And what you're starting to see here is, without a video of this, you can't tell, but this is as far as we could get that hydrophilic dilator to go without encountering significant resistance. We actually had an axillary access for anticipated need for through-and-through wire access, given how tortuous the iliacs were. So we felt pretty confident that over this through-and-through wire, we should be able to advance our device. So we pushed harder, and it's a little difficult to appreciate on these still images, but you see sort of infolding of the main body portion of the device, and still just an inability to really track the dilator above that level. And so, again, we continued trying. We got access with a different sheath. We tried recannulating things, assuming that we were probably stuck on a stent strut. We got access from the contralateral side. We tried a bunch of different maneuvers. So we got a pigtail catheter down from above, again, just to try to better understand which plane we were in between the existing devices and the wires. And you see that this catheter is clearly outside of the device. So at this point, we were starting to think very seriously about how we could safely do this. We tried recannulating several times, as I said. So again, our hypothesis was that we were stuck on a internal stent strut, and we were trying to just get not stuck on it anymore. So between our access from above, our access from the contralateral groin, we tried several different ways. And each time the tortuosity was very challenging, but ultimately we were able to get what we thought was into the main body device. And we even used a balloon to verify that we were inside the limb at one point and free of any stent struts. We tried snaring the wire from the left, as I said, and advancing the device from that side, but again, we had similar problems kind of no matter where we tried from. So we ultimately aborted this case. So what went wrong? Well, I think, we knew it was an AFX device, and we knew that in that scenario the PTFE fabric is on the outside of the stents, in contrast to all the other devices on the market. And the fabric is only secured at the proximal and distal aspects. And billowing of the fabric has been well described. In fact, type 3 endoleaks, the reason we were performing this case, have been well described when it actually led to the recall of the device from the market in the US because of this high rate of type 3 endoleak. So when we're looking at this, you see in this yellow circle, we presumed that our wire was likely through a stent strut, and we thought we could navigate that. But what's really harder to understand is why we just couldn't. We could not seem to overcome that. We re-advanced, as I said, several times, and even when it appeared as though we were completely free of that, we ultimately had challenges no matter what we tried. So as we continued to push, again, just trying to be a bit more aggressive, we saw that the friction on the distal seal stent was now causing it to invaginate on itself. So at some point we felt as though we had a higher likelihood that we were going to make him worse instead of better, and that we really needed to change our strategy. There were a couple of points in time when the anesthesia team was concerned that we had perhaps ruptured the iliac, so we did take some pictures to confirm that we hadn't done that, but we did understand that we had the potential to make this patient worse without actually treating his aneurysm. So what were our next steps? Well, we woke the patient up. We explained to him the situation. We admitted him for observation, and we got a repeat CTA to better understand if we had, in fact, done any damage to that iliac. And what you see is that the right common iliac does have a high-grade stenosis, just distal to the steel stent from probably some sort of dissection that we created. So we went ahead and we did an open explant of this device, and it was sort of fascinating to see that there was just a really large hole in that PTFE fabric in the mid portion of the device, consistent with the type 3B endo leak, as we sort of suspected, and consistent with how our pigtail catheter was frankly just outside of the main body of the device. The patient tolerated the procedure well and has recovered nicely. In fact, this is his 1-month postoperative scan, which obviously looks much better than it had pre. So lessons learned. FBEVAR for failed EVAR is simply harder. We can usually overcome the challenges of misalignment, of obstructing stent struts, and increased friction, and even eye fatigue just by sort of having another set of eyes and taking breaks periodically. But it's never what you're anticipating in vascular surgery that causes the greatest challenges. And quite frankly, sometimes the most important lesson learned is that the hardest part is knowing when to stop and safely get a patient through an operation instead. Thank you.